I'd like to now invite our four panelists to join me on the panel titled How Payors Are Seeking to Advance Maternal Health and Mental Health, and of course, maternal mental health. And they were able to catch part of this last session. So much was discussed in our last 2 days together around the role of payors. I'd like to first introduce Jeff Miklas, who is the Executive Director of the Healthcare Transformation Task Force, which I'm honored to serve on the board of with many other policy advocacy organizations and healthcare payers. He will join us to discuss reimbursement and value-based mental health care and maternal health care. He's an attorney by training and served in several other organizations, including as counsel for the Healthcare Financing Administration in the U.S. Department of Health and Human Services, so many important roles that he's played. And he's also a father of 4, which I'd like to point out, anyone that has more than 3, I think deserves an award. So Jeff, hats off to you and your wife, Monica. And I'd also now like to introduce Dr. Jennifer Christian Herman. Dr. Herman is a licensed clinical psychologist and the vice president of the Mind-Body Medicine at Blue Shield of California, a nonprofit health plan or insurer covering 4.8 million people, including Medicaid and commercially insured patients. She leads the evolving portfolio, as you can imagine, even just hearing our conversations today, things are ever changing, of innovations that leverage technology, clinical interventions, and more focused on behavioral health, lifestyle medicine, social drivers of health, digital therapeutics, and more. She's responsible for transforming behavioral health care for her members and their providers by expanding access to care and doing other things like improving integration of behavioral health care into primary care, which we'll talk about soon, and enhancing care coordination. Dr. Christian Herman is also a member of our board of directors, which I'm thrilled about. Thank you, Dr. Christian Herman, for being here. And next, I'd like to introduce another payer partner, Dr. Luis Torres from Cigna and Cigna Corp's National Behavioral Health Division called Evernorth Behavioral Health, which he'll talk about in just a moment. He serves as the medical director for these organizations. He has a passion in addressing health disparities in mental health, which you'll hear about on our panel. He will participate on this panel discussing payer views and interests in maternal mental health and share his experience with health disparities. He has served as the lead medical director addressing equity in these roles and participated as the CEO in the CEO Action for Racial Equity Fellowship and was named one of the top most influential minority leaders in 2022 by Fierce Healthcare. That is incredible. I also want to acknowledge that Blue Shield of California and Cigna are both sponsors for this event, and we couldn't do it without you, and appreciate your investment in this organization and also this event. And finally, it's a deep honor to introduce Elizabeth Mitchell, the President and Chief Executive Officer of the Purchaser Business Group on Health. As President and CEO, she advances PBGH's strategic focus areas of advancing primary care and value-based purchasing, and leads PBGH in mobilizing healthcare purchasers and payers in elevating the role and impact of primary care and also mental health care. She previously served as a Senior Vice President for Healthcare and Community Health Transformation at Blue Shield of California, and also has supported work led by the National Quality Forum around measuring what matters. Well, welcome to all of you. I think this is much anticipated panel, and we're grateful that you're here with us today. I wanted to start by asking Jeff, if you wouldn't mind, Jeff, to just introduce to us this concept of value-based reimbursement and value-based care for those who are hearing the term but just can't quite figure out what does it mean in mental health care and maternal health care.
Happy to, Joy, and thanks for the invitation to be with you today. Just maybe by way of background for folks on the call who may not be familiar with the task force, we're an industry collaborative made up of purchasers, payers, providers, patient groups, and partners, transformation partners, all committed to accelerating the pace of moving to value-based care. It's really interesting in our evolution over our almost 10 years that we really have been an organization that's been focused on value-based payment. But I think we've evolved into thinking to say that we really need to think about the care delivery model first and have the payment models be in support of that. And I'll just say our work in the maternal health space is really kind of crystallized for that. So, where we started in 2014 was with the triple aim, right? Higher quality care at lower cost to produce better population health. That really remains our North Star, but we certainly think about things and the related issues much more deeply, advancing health equity, really focusing on person-centered care, making sure that the person is at the center of their care delivery. And a lot of what we've learned really over time has been in the maternal health space. I'm sure we'll get into that a little bit more in a bit, but it's really been interesting to learn how you have to get the care delivery model right before you can really align the financial incentives around that. So that's an overview just really generally of how we think about value-based care. We're model agnostic. We just want to see the system change. There's different models that work in the commercial space and work in the Medicare space and the Medicaid space. And so really listening to our members think about the different perspectives they've learned is really what we bring to the table. And it's great joy that you serve on our board. And we're also appreciative that we have Blue Shield California in our membership as well.
Great. Thank you so much, Jeff. Elizabeth, I'd love to turn to you and ask you to share a little bit about who are purchasers. I think many of us know the word payer. Tell us a little bit about who purchasers are, and then also what is their role in addressing maternal health, maternal mental health, and just quality overall in the health delivery system.
Sure, thank you. I do identify as a purchaser here, or at least speaking on behalf of purchasers. We're a 501c3 nonprofit. We've actually been around for about 35 years, and we are a purchaser-only coalition. Our members include employers like Walmart, Apple, Microsoft, Boeing, just very, very large employers, and also public purchasers like CalPERS and Washington Healthcare Authority and State of Colorado. So it is both public and private purchasers, and collectively they buy healthcare on behalf of over 21 million Americans. So they are very invested in the value of the U.S. healthcare system. I would say they are concerned about our trajectory because costs are going up and quality and access are actually getting worse. So value is declining. And they see their role, at least my members, as playing really taking a leadership role in changing that trajectory. They are particularly focused on maternal and mental health. Commercial purchasers pay for over 50% of the births in the country. And I think everyone here knows we have a significant crisis, both in maternal health outcomes, but also in equity, because mortality rates for non-white women are actually twice as bad or even higher than they are, and they're not acceptable for anyone. So our members really took it upon themselves this year to really lay out a new set of standards and identify what employers and purchasers can do to change that. Obviously, it's going to take all of us, and I'm happy to share more of their priorities later, but they really want to be catalysts for significant and really urgent change.
Great, thank you. I think we'll turn next now to those that you purchase healthcare from, your members purchase healthcare from, and I'll start with Dr. Christian Herman at Blue Shield of California to talk a little bit about how Blue Shield of California and your department specifically, Jennifer, is looking at whole person care and mental health care.
So we definitely are looking at. I mean, I think the mind body medicine label of our area is really bringing the medical care and the behavioral health care together. And so through scaling collaborative care and other models, that's been a big area of focus around maternal mental health, focusing on the same theme. And I think plans can play a role in supporting our members with the care that they need, with advocacy, with navigation, making it easy, providing resources, also in partnering with our network providers, helping them to have the tools that they need, whether it's a depression, screening pathway where the billing guidance is very clear, monitoring and helping lower performing providers who are not screening or providing the follow-up for pregnant individuals, and through other collaborative processes to really make sure that everyone has the tools and resources they need to really provide evidence-based care and support members that are pregnant.
Thank you. Thanks, Jennifer. I'll turn it over to you, Dr. Torres.
Sure, absolutely. And thank you so much for having me today in this, great panel. So to answer your question, I mean, at Cigna, we are deeply committed into advancing integration of behavioral health, but into the primary care settings, including the space, obviously, of maternal health. So we really understand the impact that collaborative care and integrated behavioral health solutions can have not only on patient care, but also on the overall experience, the engagement, and reducing really even like health disparities. So our approach really involves actively supporting these models where we put in the patient in the center and of the equation, and then we wrap them around with the primary care doctor, behavioral care manager, and then a psychiatrist, all working together to promote whole person health and improve the customer vitality. So in doing so, we're working closely with medical groups, outside health centers, and co-locate behavioral health clinicians so we can ensure comprehensive care for every individual. And we have ambitious goal. By 2025, we aim to make depression screening and follow-up of any of those positive cases a mandatory quality measure on our value-based care contracts with our CAC. By 2026, we are continuing to develop and expand our new Evernorth Behavioral Care Group. And we foresee there opportunities to support integrated referrals models and also expand solutions addressing social determinants of health. And in order to achieve all this, we're focusing on the following strategies. First, we're enhancing our partnership with primary care providers, increasing really the focus on mental health integration. We are also engaging with the market to understand what are the integration barriers out there, what are the best practices out there. And secondly, we are leveraging technology and data insights to develop evidence-based MART tools. And also, we're trying to expand our clinical data to include, a focus more specific in behavioral health. And then, I mean, eventually, we just want to be able to inform providers about patient risk, practice opportunities that need improvement, practice performance. So like really creating also navigation assets that will navigate or facilitate in-network referrals, and timely care coordination is also within our radar. And let me end by saying that we really truly believe that by integrating behavioral health into primary care, we're just not going to be treating symptoms anymore. We are going to be transforming lives. So at Cigna, we are committed to driving better outcomes and enhancing well-being and ensuring that individuals receive holistic, equitable, and comprehensive care.
Got it. Very good. Excited to follow the work that Cigna and Blue Shield of California are doing along these fronts. I'm hearing the voices of providers in my head, primary care providers, or perhaps in our case, obstetric care providers like midwives and OBGYNs and even family practice providers who are delivering babies, saying, that all sounds good. Maybe I'm in a small practice, and so collaborative care, the COCM model, which we discussed on a panel yesterday, is sort of out of reach for my small practice. But I am interested in doing something around behavioral health integration, and especially if there are mandates to screen for maternal mental health disorders like Jennifer, there is in California, Blue Shield of California, rather, I know is living this, and even mandates on insurers to address maternal mental health through development of programs and quality management oversight and such. So the other big thing I think providers such as PCPs and OBs might be thinking about is just payment and reimbursement. And so, Jeff, I want to turn it to you to talk a little bit about what are some of the behavioral health BHI reimbursement strategies or other value-based strategies that you've seen plans talk about that seem to be working around integration?
Yeah, well, I definitely think it's an evolving space. I think in the work that we've done since 2019, we convened a group called the Maternal Health Hub, which was funded by the Commonwealth Fund and had a learning community. And what we found was really the care delivery model needed to be solidified, and then the payment model kind of built around it. And so certainly there's reticence of providers to take on risk in that kind of downside risk payment model. And so there's really had to been kind of slow walking that and really getting the care model correct. So we all know of the advances with regard to extended coverage periods for postpartum in Medicaid, bringing on doulas and midwives to participate. That's a great care delivery advancement. However, that also complicates the payment model, right? Because some of those folks haven't really worked in the value-based care world as much. And so again, with the payment model being in service of the care delivery model, we are seeing from our membership kind of different levels of care and risk that's being assumed. In some cases, we have a payer member in particular who is pushing for greater risk of the providers, but is contracting with a transformation partner who can partner with the provider to help kind of mitigate the risk assumed with that model. The one model that I wanted to raise up today, which I find is very interesting, is developing, is something our member Elevance Health is doing. They are focusing both on their commercial book of business as well as their Medicaid line of business to implement what they're calling OB practice consultants. And they're employed by the payer. And then they're distributed and have access to the OBGYN and the OB practices, the doulas, the midwives across their network. And they serve as either on-site support, or they can be contacted virtually as well. And what they are doing is really trying to improve the providers' understanding of what is available to their enrollees across those different lines of business. So in the Medicaid line of business, they also have a value-based care model currently where it's basically pay for performance based on the HEDIS measures. And so, having that prenatal visit as quickly as possible, making sure the postpartum visit happens is critically important. And both of those opportunities give the practice consultants the opportunity to kind of create the toolkit by which the providers can talk about, what you should be looking for as a patient, as a birthing person, while you're going through the prenatal stage and in your postpartum stage, and signals that should be concerning to you if they arise. And then therefore, the practice consultants can help those people get more in contact with the additional handoffs and the care needs that they have in other places. I think there's still evolving thinking about how you try to make sure that's part of a payment model. It's not necessarily part of what you would say as a traditional maternity care bundle, as it were, but the importance of those care delivery handoffs is critically important. And just to kind of show some scale of this program, there are currently 35 practice consultants supporting 22 Medicaid and 10 commercial plans, and they had over 8,000 provider visits in 2023. They are reporting a 95% provider satisfaction rate. And what I think is interesting is they've also shown that they have saved 5% of expenditures on the mom care delivery and up to 10 on babies in kind of their first year of the program. And so they're seeing some real cost savings there too. They're also seeing low birth rates and preterm birth rates are down materially, while the timeliness and the adequacy of both prenatal care and postpartum care have increased. So very promising there, employing those care delivery to make sure that the enrollees of their plan are getting access and handed off appropriately across the continuum.
Thank you, Jeff. That will be interesting to read more about as things become more documented. Jeff will share it with the network. I appreciate that insight. I wanted to share 2 panels ago. We heard from Dr. David Kelly from Pennsylvania. They're the state with the highest maternal depression HEDIS screening measures. And he shared that they've implemented a maternity gain share component of their maternity care bundle where OBGYNs and other obstetric care providers get more if they screen and treat maternal depression, both in the prenatal and postpartum period. So I wanted to share that with all of you while we are here. And I'm going to turn it now to Elizabeth to share a bit about the framework that has been just released in a report that I believe you published last week and that we're really eager to hear more about.
Sure, thank you. And we've actually held off on publishing because we are actually revisiting the payment reform section because we're trying to come up with the most effective payment approach for rural areas and maternity deserts, which is not easy. But that is a huge crisis for our members. As you know, companies like Walmart have employees in every county of the country, and in many counties, there is absolutely no OB care. So one of the things that Walmart is doing, and they are one of the co-chairs of our maternity work group, they are literally hiring doulas when there's no other maternal health workforce in these communities. And many of our members are actually seeking to replicate that. So what we've done is we've spent the last 18 months working across our membership, public and private members, chaired by Walmart and Qualcomm, to say what are the most important things from a purchaser perspective for their workforce. We have come up with a priority measure set. It includes C-sections, it includes prenatal depression screening and follow-up, and postpartum depression screening and follow-up. So again, we're hearing a lot of alignment here. These are the things that they're going to put into their contracts with their payers and provider partners. Postpartum follow-up and care coordination, social needs screening and intervention, patient experience, CAPS and HCAPS, severe obstetric complications, and then percentages of midwife deliveries and maternity patients who used a doula. So they try to just outline a clear set of metrics that they hope to see sort of movement on. I will say, however, PPTH collects plan data on behalf of most of our members, and we are seeing C-section rates this year. We've got the data back, in some cases up to 47%. And really the range is about 33 to 36% across the country, but the Healthy People 2020 goal was 23%. So we have a long way to go. And so we are trying to understand what role we can play, not just setting measures, but then paying differently. Our members want to pay more and pay differently. For primary care, as we heard, they want to pay prospectively, flexibly. They want to pay more for primary care. They are not seeing that happen despite their best efforts. And a lot of us are just sort of, we seem stuck on this fee-for-service, chassis that we can free of and remove the payment barriers for primary care, for mental health care. We are absolutely prioritizing behavioral health integration and looking at the barriers, not only of sort of carve out networks, how do we get them into the practice, but also paid for and having effective data sharing. So there are so many delivery system barriers that, become reflected in poor outcomes that they are ready to take on, and they want to play. So many of them are looking to cover doulas. That is a top priority. They're getting a lot of pushback in some cases. They are trying to offer that coverage, and it's not as easy as it should be. They are trying to expand, in some cases, telehealth in rural areas. And then we encounter barriers like not being able to practice across state lines, or there's just a lot of barriers to get the kind of care that employees deserve, and families, obviously. But they are willing to sort of really step into a leadership role and partner to do that.
Really helpful to hear those priorities. And I think our audience would sort of second all that you said, or plus one, I guess is the new phrase now, all of the things that your purchasers are looking to do. And of course, we know from the plan perspective, I spent 24 years at Cigna. That's where I met Dr. Christian Herman, and I've had the good fortune of learning so much about the health delivery system from my partners like Dr. Torres, on the line that it's much more difficult than we think to do some of this work. Yet we know it's critically pressing. And so I want to turn to you now, Dr. Christian Herman and Dr. Torres, to talk a little bit about if you have more to share around behavioral health integration, or even network adequacy and reimbursement for behavioral health providers. How are you thinking about that, or other priorities and programs that you're putting in place to address mental health or maternal health specifically? Jennifer, I'll turn it to you.
Sure. So we have really looked across our lines of business and addressing things, similar themes, but slightly different mechanisms. So For our Medicaid membership, have a very robust maternal mental health program. As I said, it incorporates our social services, definitely the interconnection between social drivers of health and mental health, as well as racial equity and issues in that, really trying to have a very comprehensive approach. Doulas are a really important part of that in both Medicaid and in our commercial membership. And so just making sure that both our providers and also our members understand what's available to them and how to connect. And we think doulas are a really important piece of that, both during the pregnancy and even up to 12 months postpartum, play a role, across all of those different outcomes. And our commercial membership, and often in partnership with the employers that purchase our insurance, offer a number of programs using technology. So Maven is one program that focuses on sort of a virtual practice with OBGYNs, lactation consultants, mental health specialists, career coaches, advocates, sort of the whole picture of what a pregnant individual might need. And similarly, our piloting programs around doula support through in partnership with Mommy to see how we can bring that to scale across all of our commercial membership.
Thank you, Jennifer. Dr. Torres, anything else you want to add?
Sure. I mean, I can talk a little bit about some of the initiatives that we have been doing at Cigna. There's a lot of them, but I highlight maybe a few of them. One of them is a program called Expecting More, where we offer chat support between members and then Cigna nurse advocates, integrating behavioral and clinical support throughout the pregnancy and up to 1 year postpartum. Additionally, we had enhanced programs to provide dedicated support to condolences cases when a member had miscarriages. One of my favorites is the pregnancy support pilot that we have, that we're promoting healthy birth outcomes and improved prenatal care, targeting high-risk pregnancies and aiming to reduce racial disparities in pregnancy-related outcomes. So through this pilot, we provide interventions such as social determinants of health screening, free prenatal vitamins, behavioral screening, and even transportation arrangements. And then another one that we have developed is the Healthy Pregnancy app, or partner with them, designing to empower members with digital tools and information tailored to the pregnancy journey, including specific content that are specific for some racial groups. We have content for Black women, for example. So, I mean, these are some of the initiatives that we have collectively done to reflect our commitment to maternal health at Cigna.
Thank you. Yeah, but it's very evident, I think, that everyone cares about these populations. The difficulty, I think, is sort of the webs of programs and payment needs, and where does the rubber really meet the road? What can we do that's very meaningful and that supports the providers in this space as well? A couple thoughts that I wanted to leave folks with, and then Jeff and Elizabeth, just 30 seconds from you after I share some thoughts, and we'll wrap the session. One thing that we've heard over and over again in our last 2 days together is workforce, and these thoughts that payers can play a role in addressing behavioral health workforce. I wanted to touch on something that you shared, Elizabeth, around doula care for those in commercial programs. We know one of the challenges around doulas or community health workers or even certified peer support specialists is that many payers are not in a position, they feel, to add these providers to their network if they're not licensed in the state. And some states still don't have state licensure in place for CHWs and doulas in particular. One thing that I wanted to share that I actually learned from a Cigna behavioral health director that could be of interest to all of us is that there might be an opportunity to publish policies around how existing obstetric care providers, for example, or even hospitals could employ and bill on behalf of, so employ a certified doula or non-certified doula, rather, doula or CHW that works under the direction of a licensed provider to kind of overcome that challenge around non-licensed providers. And so just like ABA providers for autism work in that capacity, we could do the same for doula care. So wanted to share one example. We also hear that we would love to see payers do more around support groups. So we know there's group benefits in behavioral health, but yet they seem to be hard to find, groups and provider directories. So one thing we might be thinking about also home visiting. We know Medicaid programs, there are some Medicaid programs that actually bill for home visiting, and it's something I think that we can explore on the commercial side and explore more widely on the Medicaid side. I'm going to leave it at that, but wanted to give you each, Jeff and Elizabeth, 30 seconds to respond. Anything else that you want to say before we close out the panel? Jeff, I'll turn it to you first.
Well, I think you articulated the workforce concerns and challenges really well. I'm optimistic. It seems like the policy is moving in the right direction. We always like these things to go faster, but they are headed in the right direction. I think the thing that I'll raise up that's a little bit different, that hasn't been mentioned here, I'm sure it's been mentioned other places in the conference, is the new TMA model out of the CMI Innovation Center. Really excited about the possibilities there. I'm glad it's actually going to be available to more states than some of the other state-based models they've rolled out in the past several months. Again, not necessarily a value-based payment model, but setting the right tone for, I think, the appropriate care delivery model. Still the devil's in the details on how much behavioral health integration will be there, but certainly something we've been advocating for since 2019, and we were really happy to see the Innovation Center deliver on that.
Oh, great. And CMS was just on a panel two panels ago and announced that model and that there's going to be some deep work around behavioral health integration. So
we'll be working with them, Joy, with your help.
Yeah, all of us rolling up our sleeves together. Elizabeth, final words from you?
Yeah, I don't know if this is what you're looking for, but I also have 4 kids, and I had 2 of them in London and got to benefit from doulas, home visits, all the social supports. So I guess I would just say we know what works. There is evidence out there about what is needed to help keep moms healthy. Unfortunately, our system creates so many barriers to them. We are, ready to partner to, get the real and SOGI data and really understand where the inequities are coming from and pay differently for the care that we know keeps people healthy. So I'm really hoping that there can be a partnership, purchasers, payers, providers, government, all of us, because some is not a number, soon is not a time, according to Don Berwick, and we have got to just make this more urgent and really see some measurable improvements.
Great. Thank you so much to this panel. I know there's so much more that our listeners and a network want to do here. And so let's keep the conversation going. I'm dropping a link into chat for our Whole Mom standards for payers or insurers that we are promoting. We haven't released them officially. They were refreshed this year thanks to support from a philanthropic partner. But look forward to continuing the conversation and partnering with each of you. Thank you again to Blue Shield of California and Cigna Evernorth for your sponsorship of this event. And we know that you're going to be a great partner in this work. Thanks, everyone.